Hey everyone, welcome back to another Intellect nursing video. So in this video, we're going to go over myocardial infarctions. We're going to go over the signs and symptoms, the pathophysiology, risk factors, complications, and the treatment and management. So let's get right into it. So before we dive right into pathophysiology, let's just simply define what a myocardial infarction is. Now, of course, the general term could be called a heart attack, but there's also things such as understanding STEMI versus NSTEMI. What are those? And what is the different types of angina as well, because that can also help you understand how severe a myocardial infarction can be. So first starting off with was very simply, what is a myocardial infarction? It is death to the muscle tissue due to inadequate blood supply. So just like any other muscle, the heart is a muscle, right? But if you had any other muscle in your body that had no blood supply to it, it would eventually die. It would eventually, of course, stop functioning. So your heart is also in constant need of blood supply. So in that blood, of course, carries nutrients and, of course, most importantly, oxygen. So without that, of course, the heart can no longer function. So we're going to talk about those coronary arteries that supply blood to that heart muscle tissue. But just to very put it simple to what the definition is, it is lack of blood supply to the muscle of the heart. Now there's different severities of it. Sometimes the blood flow is completely blocked in a certain portion of the heart, or it can be partially blocked and gradually cause a myocardial infarction or muscle cell death in the heart. So let's go into that. Let's go into the different types of angina. So angina is pain. So it's chest pain related to myocardial deficiency of getting oxygen and blood supply. So there's stable angina, there's unstable angina, there's other types of angina such as variant angina. Let's just get right into that first, and then we'll get into what the difference is between STEMI and non-STEMI. So what is stable angina? So you can think, of course, if you have a stable patient, right? Something not so severe is going on. So stable angina is chest pain. You have chest pain, and it's usually related to a deficiency of oxygen reaching that muscle tissue in the heart, but it's stable. So it's not necessarily causing a full-on heart attack or anything like that, but it is a warning sign. It's a warning sign that there is a deficient amount of blood supply coming to a certain portion of your heart. It usually occurs with activity. So if you're exercising, maybe having some chest discomfort or some chest pain, it usually doesn't last more than 5 minutes though, and it goes away completely when you rest. So it's usually associated with some increased activity, which makes sense because when you exercise, you're increasing the myocardial, the muscle of the heart, demand for blood supply. So just like anything else. So if I'm doing a bicep curl, well, blood just naturally goes to it, right? That's because the blood is there to supply more oxygen. There's a bigger metabolic demand that my bicep needs when I'm doing curls. So same thing with the heart. So when I'm increasing activity, well, my heart needs more oxygen and blood supply to keep up with the pace, to keep up with my cardio that I'm going on. If I have a deficiency of blood supply going to my heart, if I have maybe a slight block somewhere, well, I might have some chest pain. That is your stable angina, but it goes away after resting. Now, sometimes it might not go away. Sometimes you do need some nitrates, and it does depend on the characteristics around it. So if it doesn't go away after 5 minutes, if you're known to have this issue, it can be related to some other diseases, well, then you would give some nitrates to relieve it. And if the nitrates work, that's your stable angina. Now your unstable angina. So now we're talking something a little bit more significant, right? So if you know that stable angina usually doesn't last more than 5 minutes, it relieves after rest. Well, as you can assume, unstable angina is the exact opposite. So you can rest, doesn't matter. It's unstable, there's something more severe going on. You can give nitrates and it doesn't work a lot of the times. And then now it's lasting over 5 minutes. So this is getting worse despite the initial treatments for angina. So that's your unstable angina. So which is leading to your myocardial infarction. Now there's other types that you'll need to know about, and it's not necessarily the highlight of this video, but we're just going to shortly explain them since it's kind of related. There's something called variant angina, and that's related to a severe and sudden chest pain that's related to the coronary spasming. So if you have a vessel that spasms, right, you might have some pain localized at the area. Well, now here it's kind of the same sense where the coronary artery itself has having a spasm and it increases the pain just suddenly and acutely. And it could be very sharp. pains. And sometimes this happens when you're at rest. At night, especially, is when it more commonly happens. But that is your variant angina. It's not necessarily related to activity at all. It's not necessarily anything concerning necessarily, but it is a certain type of angina. And then you have your microvascular angina, which is a longer lasting pain. So it's not something that's so sudden or acute. It's not like your acute angina with unstable or stable or variant. It's something that's kind of there over a long period of time. And it can occur just with normal daily activities. It usually doesn't cause or need any sort of treatment, but of course, that's another type of angina that you may need to know about. Now getting into STEMI versus NSTEMI or non-STEMI. So STEMI stands for, it's S-T-E-M-I. It's S-T, so meaning from the PQRST, so your heart ECG rhythm. It's ST, that segment there, elevation, myocardial infarction. That's what STEMI stands for. Now, NSTEMI means non. ST elevated, myocardial infarction. So it's really that simple. A STEMI you're going to see on your ECG, or really your EKG, your 12-lead EKG is what helps confirm this. And ECG is pretty unpredictable or non-reliable in a lot of sense. You usually don't use that for a diagnosis unless they absolutely have to. It's pretty standard to do a 12-lead EKG because it also helps identify the segment or the portion of the heart that is getting impacted or lack of blood supply. So you have your 12-lead EKG, and that ST segment is elevated. So we'll throw up a picture here so you can see it. So there's an obvious change in the ECG rhythm, and this usually means there's a more severe lack of blood supply to the myocardial tissue, and there's some damage that's already been done. So that there is some significant damage going on in the myocardial tissue. Versus your NSTEMI is you would not see anything on the 12-lead EKG, but it doesn't mean there is not a problem going on. It doesn't mean there's not any damage to the myocardial tissue, but it typically means that it's less severe, but not always. Sometimes there's just some surprises going on. So we check blood levels such as your heart enzymes, such as your troponin or your CKs. We'll go over that in a minute. But just to really put it simply, what is a myocardial infarction? Where are all the variations? So we went over the anginas, and we just went over the different types of a myocardial infarction, so your STEMI or NSTEMI. We're not going to get in so much depth of the different types of STEMIs and things like that because it's not necessarily needed for your nursing exam or your NCLEX. That's something more on when you go take your CCRN course. So if you're thriving to be a critical care nurse, you might want to take your CCRN, get your certification there. You'll be learning much more about those specifics in your hemodynamics related to it, but do not need to know for this NCLEX and a nursing exam. It does not go in that much depth. So as you can assume, if there's a decrease in blood supply, we already sort of talked about this, but just to really summarize, well, if you have lack of blood supply to anything, it's going to die. So the heart tissue itself is going to get necrotic. It's going to stop functioning. So when that heart stops functioning, you have decreased contractility, you have decreased blood flow and oxygen throughout the rest of the body. It's a major issue, and you really don't have that much time to solve it. So we're going to get into management and treatment. Let's first go over the very simple signs and symptoms. So of course, your hallmark sign and symptom is chest pain, and it's usually unstable angina. Stable angina is not necessarily a myocardial infarction. Unstable angina is when you have to start looking at it. So that's your hallmark sign and symptom, chest pain. It could radiate, it could not radiate, especially women have atypical signs and symptoms. So of course, you can get your perfect picture, right, where you have your patient who has left-sided chest pain, they're short of breath, they're sweaty, diaphoretic, they have radiating to the left jaw and down the left arm. That's your classic sign and symptom of myocardial infarction. But in the real world, just know that sometimes there are some random signs and symptoms that can happen. It can be, maybe it's just dizziness, or maybe they have blurry vision randomly. Sometimes those things can happen, or maybe it's back pain. So like the back, sometimes it's not necessarily chest pain, it's back pain. That can radiate, and that's sometimes more commonly seen with women especially. But if you think of that classic picture for your NCLEX and your nursing exams, just think left-sided chest pain. It's very severe. It feels like an elephant is sitting on my chest. It's dull pressure, right? And then you have radiation up to the left jaw, down the left arm. You have shortness of breath. You have tachypneas. You're breathing really rapidly. And of course, your heart rhythm may be elevated, or your heart rate may be elevated. So those are your classic signs and symptoms. They're diaphoretic, they're sweaty, they look very distressed. So that's your very classic sign and symptom. Now going on, what are the risk factors? So you identified, hey, they have unstable angina. They have these signs and symptoms, and classic, maybe non-classic, right? But what are those risk factors that may be associated? So right away, heart disease. So you have coronary artery disease. So plaque buildup in the coronary arteries itself. That's the direct primary impact that this could cause as a myocardial infarction. So behavioral type things such as smoking and diabetes, obesity. So those things that are more likely to cause plaque buildup. So high cholesterol. So LDL is your bad cholesterol. Low HDL. So that's a protective cholesterol. If it's low, then you don't have much protective to prevent plaque from building up in the vessels. And if you're over the age of 40, you're at higher risk for this because over time, things are more likely to slow down in that bloodstream and build up plaque. There are many other risk factors. You can think of hypertension, you can think of heart failure, you can think of all these other things that maybe not be directly related to plaque buildup. But those are your main ones, those classic risk factors. Now, complications. When you have a death to a muscle tissue, you're going to have heart failure. You're going to have a decreased ability to contract. So heart failure is an immediate one. You can have fatal arrhythmias such as VTAC. So it can mess with your conduction system and cause it to very rapidly have a reaction to it, such as VTAC, so which is a ventricular arrhythmia. You can have VFib, you can have heart block. So it all depends on where it is actually localized, where that blood supply is actually not reaching. Now, of course, stroke and of course, death is another complication. Now getting into diagnostics. So how would we diagnose somebody with a myocardial infarction? So once again, that 12-lead EKG is your hallmark diagnostic. So of course, if it's a STEMI especially, it's going to be very easily to identify that. What about if it's not a STEMI? Well, we need to also, no matter if it's a STEMI or not, we're going to be checking cardiac enzymes. So your troponin, your CKMB, and of course, we're going to do the whole thing too with CBC, CMPs, check all the electrolytes, check your blood levels, check your cholesterol levels and see if there's predetermining factors there. So, but the big ones here, troponin's a big one, the CK, so creatine kinase is another big one. Those will actually tell you whether or not there is an immediate issue going on. So if the troponin's really sky high, that tells you that at least they have an NSTEMI, because if there's no ST elevation on a 12-lead EKG, doesn't mean that they're out of the weeds here with the myocardial infarction. They could still have one, and it will showcase that with a troponin level that is above 0.04. So those are those easy diagnostics that we can have for myocardial infarction patients. Now moving on to treatment and management. So very simply, and this is not necessarily evidence-based practice anymore, but a lot of times you'll hear it in educational purposes for just remembering the general purpose of the treatment. What are we trying to achieve here? And that would be MONA. So you might hear, MONA, it's a mnemonic that stands for morphine, oxygen, nitrate, and aspirin. Now, recently, not so recently even, a lot of the studies show that morphine is not necessarily a immediate intervention that we want to do because it could actually prevent the effectiveness of anticoagulants, so your aspirin or your antiplatelets. That's not necessarily something we just jump into right away. It is a mnemonic that we will say for educational purposes, but it's not necessarily something that your physician will order right away. It's not like it's a treatment bundle, say. And it all depends on, and this will all vary anyways, and it all depends on what patient you have in front of you. So morphine is used for pain control typically. It's used to also decrease the myocardial demand. So when you decrease that, it allows you some more time. You buy some more time basically, because you're relieving that, you're dilating those coronary vessels. The attempt is to dilate them, but it's not as effective as nitrates. But it does decrease the pain. It does decrease myocardial demand. So you're kind of decreasing the metabolic demand. So if I'm doing bicep curls once again, I'm essentially saying, hey, you don't need that much blood supply anymore because I'm allowing you to relax now. So, hey, we're going to buy you some more time. Now, oxygen. That's another one that's actually not so much immediate intervention. Now, realistically, if you're a nurse at the bedside and you have a patient who's short of breath and their SpO2 is, their oxygen saturation's 89% or whatever it is, then yes, we're going to be putting some oxygen on. But the real purpose of this is we're probably going to be doing some arterial blood gases to check. And if those oxygen levels are at a certain point, maybe we don't go straight to a non-rebreather, right? Or going up in ventilation. This is something to keep in mind of, but realistically, that is an intervention that we're going to be doing is oxygen supplementation, because once again, they already have a lack of blood flow to that myocardial tissue. So yes, we are going to supplement with some oxygen. Now, nitrates is still some of the main interventions that we'll do for these kinds of patients, because nitrates dilates the coronary arteries. And that's exactly what we want to happen, especially if we know there is either a partial blockage or a complete blockage, right, of blood flow going to that myocardial tissue. We want to dilate to increase the blood flow to the heart. So that is going to definitely do that. It is going to also, we have some considerations. It's going to decrease the blood pressure throughout. So if you already have a very soft or low blood pressure, it's something to really keep an eye on. And of course, NCLEX and the nursing exams really love testing on this. So patients who have had Viagra, for example, some medications that are considered PDE5, so your phosphodiesterase medications, those are contraindicated with nitrates. So you always have to ask the patient if they have had that recently within the last 24 to 48 hours. So that's something that you definitely want to, of course, interview about and just know, because the NCLEX and the nursing exams will ask about this. But nitrates, do not give them if they've had that medication recently. And then you have your A, so aspirin. Aspirin is a must-have immediately. So if you have a patient who has signs and symptoms of myocardial infarction, you're going to be giving them aspirin. And it's usually around the 325 milligram dose. It's not like your baby aspirin. It's 4 of them. So 325 milligrams, it's usually one of the first medications that we're going to be giving these patients. And it's antiplatelets to help break up that clot possibly, and prevent further clogging happening in those coronary arteries. Now, we will also possibly have this patient get other things that will help decrease the cardiac demand, such as beta blockers. So metoprolol, for example, that's going to help slow down the heart rate. It's also going to slow down the myocardial demand. So you also want to watch out, once again, some other contraindications, such as already decreased contractility, so decreased pumping function of the heart. But overall, metoprolol is another common one you may see. So beta blockers, or if there's a really high blood pressure, of course, we're going to give medications to decrease that blood pressure, because that's increased resistance against the heart, which once again increases the myocardial demand. So we're really just looking at the heart and kind of seeing what are the factors that are making this heart work really hard right now. Let's relieve all those factors, and then let's now treat the underlying issue. And the underlying issue usually for this patient is that there is a plaque buildup in the coronary artery. So the primary treatment for this patient is a PCI procedure, a percutaneous coronary intervention. And they take the patient to the cath lab and they basically get rid of the clot. They'll use all kinds of different interventions that we won't necessarily go into too much detail today, but just generally know that they go to the cath lab and they get rid of that clot, whether it's through a balloon function or if it's a mesh that they insert. It all depends on how bad the clot really is. Now, if it's really bad and there's a complication such as a heart block, then you might have the patient get a pacemaker, if it's temporary. If it's an external pacemaker, sometimes they'll come out of the cath lab with those, or if it's sometimes implanted as well after some time, especially if the damage was already been done and there's conduction issues afterwards. So as a nurse, what do you do at the bedside when you have a patient who is suffering from a myocardial infarction? So if you're at the bedside and you know that this patient's about to go for a PCI procedure, of course, you're going to follow the orders that the physician was likely to order. So you're going to probably be giving some aspirin. You're probably going to give some oxygen supplementation, depending on the type of patient you have in front of you, maybe morphine, but usually nitrates will also help the pain. So they will usually stick with those first because it's a direct impact dilating those coronary arteries, allowing more oxygen and blood supply to get to that injured muscle tissue there. Of course, you're going to be looking strictly at the ECG, make sure there's no changes or arrhythmias going on, make sure that the patient's not showing any other signs and symptoms or increased respiratory distress. That's usually like your quickest find out if whether or not the treatment is improving the patient's condition rapidly or not. Now, to prepare this patient going down to the cath lab to do their PCI, you're going to make the patient NPO, so nothing by mouth, so they're not, having increased risk of aspiration. Now, sometimes, especially if PCI is unavailable, they might do thrombolytic therapy. So if they did, then you're really looking out for complications of bleeding. So definitely make sure you understand that. So thrombolytic therapy complication is, of course, that risk of bleeding. Now, what do you do when your patient comes back from the PCI procedure? So when they come back, they usually go through the femoral artery, right? So they usually stick that probe, or they insert a line and insert the probe through the femoral artery all the way to the heart to treat that coronary artery that is causing the issue, right? So afterwards, that puncture site is still going to be there, of course. So what you're going to be doing is monitoring the vascular status of that limb, because it's a big artery right there, that femoral artery. So you want to make sure that there's still blood flow going down to the distal extremity. So you're going to look for some issues such as your 6Ps. Think compartment syndrome, pulselessness, you got your poikilothermia, so the coolness of the extremity. You have your paresthesia, pallor, and then paralysis. So look out for those, see if there is decreased blood flow, and of course monitor the site itself for any hematomas that are forming underneath the skin. So just really look out for the vascular status of the leg. So what you'll do likely as well afterwards is this patient will remain supine. You don't want to put them Fowlers and where it could increase or decrease the pressure directly on. So like they have usually a pressure dressing on that puncture site. And if you have them bending, the pressure is not going to be as good, and you're going to risk the hematoma from building up in the extremity there, and of course increase the risk of decreased blood flow down to the extremity. So usually about 6 hours after procedure, they're going to be supine. You can be creative by elevating them, but making sure they're supine the whole time so that pressure dressing is directly on that puncture site. Now, of course, you're going to be usually doing some pulse checks quite frequently within that first hour, usually every 15 minutes, and then maybe every hour afterwards for that 6 hour. All depends on your hospital policy, but just know in general, you're really checking for vascular status, and you're really watching that puncture site for a hematoma building up. So now let's think about the complications around this procedure that just went on. So when you fix the blood flow problem and you immediately start supplying the heart with blood supply and oxygen again, there are some reactions or compensations that could potentially, especially if it was a chronic issue, mess around with the heart assessment here. So you could have bradycardia. If you really think about it, it makes a lot of sense. So if you've had your heart that's been working good on, maybe about 25% of blood flow for a long period of time. It's been fine, it's been compensating, right? But at a certain point, it can't compensate anymore when the plaque gets so big and blocks a lot of the blood flow. So over time, your heart's compensating. Yes, I can still function on 25% of the blood flow going to me, but I'm going to have to increase my blood pressure or increase my heart rate. So eventually, myocardial demand gets so high. But when you fix that, boom, your heart's like, wow, I'm relaxed now. So it doesn't need to pump so fast. It doesn't need to contract so hard. It has the blood flow it needs now that it hasn't maybe had for a long period of time. So it's finally relaxing, right? Well, sometimes a bradycardia can get pretty severe. So you want to look out for that. And if it does, then maybe you're going to be given something called atropine to increase the heart rate. But of course, you're really looking out for heart blocks, for example, some conduction issues. Because once again, you never know what could happen after you do reperfuse the myocardial tissue. So checking just ECG rhythms consistently, making sure you're looking out for heart blocks, of course, ventricular arrhythmias as well. Now, what happens if that puncture site does have a complication? One complication that you want to look out for is a retroperitoneal bleed. So it could either, of course, cause a hematoma at the puncture site where it's a little bit more obvious. But if you do start noticing tachycardia, of course, other signs and symptoms such as decreased blood flow to the distal extremity, and the patient has sudden hypotension and low back pain, check them for a retroperitoneal bleed. That means the patient could be bleeding from that puncture site, but going the other way, no, not at the puncture site itself. So it could be leaking back to the retroperitoneal cavity. So check that. So that retroperitoneal cavity is in the back side, and you might have some bleeding, some bruising going on, and sudden hypotension and low back pain. That's a complication of a puncture site from a PCI. So in that case, of course, you're going to rapidly introduce IV fluids and increase the intravenous fluid again. And then, of course, if you need to, you're going to be checking the CBC anyways and seeing if they need blood products. If you do see the puncture site bleeding and it's causing a hematoma, you're going to be holding that down for at least 20 minutes. And sometimes they bring in something called a fem stop. So you bring in this little device that helps to apply pressure consistently while you can do other things. So it all depends, once again, on your hospital policy, but just know those are some interventions that you might need to know about for your NCLEX and your nursing exams. All right, guys, that covers everything. I hope you enjoyed this video. I hope it was helpful to understand all the different aspects of a myocardial infarction. So all the signs and symptoms, the pathophysiology behind it, risk factors, the complications, and finally the management. Thank you all so much for watching, and I look forward to seeing you in the next one.